When we're talking about switching disease-modifying therapies, there are multiple reasons why somebody might switch. One would be that the person is not tolerating the medication. It may be working well, but it's causing them pain and suffering and poorer quality of life, and you've done your best to manage side effects, and that's a legitimate reason to switch. Or somebody might have an abnormal laboratory finding on the white cell count or the liver, and this is becoming problematic, and that's another valid reason to switch. Another big reason to switch is breakthrough activity, unacceptable breakthrough activity, that somebody has more active MS and the disease-modifying therapy that was chosen doesn't seem to have the efficacy to really control their MS damage process sufficiently. So if you had a patient on an oral, you might think about if they were having breakthrough activity, disease activity, you want to switch them. You don't want to sit there and have that going on, but you want to switch them to what you would perceive as a higher efficacy agent, and probably that's a switch to one of the monoclonals. There you're going to be looking at, well, that's great, I want to put them on a high efficacy agent, but what is the risk of the high efficacy agent? What monitoring do I need to do? How can I discuss with them what the options are? And remember, we have 3 high efficacy monoclonals, so I think you would sit down and go over that, but I think the bottom line would be for breakthrough disease activity, you would want to make a switch to another DMT that you perceive, different mechanism of action, had higher efficacy.
Sometimes we have to switch treatments for patients. If they can't tolerate a medication, or there's a safety concern that comes up, or maybe the efficacy of the drug is not adequate. So we look at this and we factor in, okay, so they're on this treatment, whichever one it is at this point. We need to know whether or not the drug has had its full benefit in the time frame that we hope that that is going to be. So let's say somebody starts a new medication and they had an attack, let's say, the next month. Well, it may be too soon to make a determination if that medication is inadequate. We might say 3 months is probably not a bad idea. Some people like 6 months. Depends on the drug, depends on when that drug becomes fully active and what you would expect to be hoping to see in terms of suppressing disease activity. But when we look at patients, we look at their clinical features. We look to see whether or not they are having attacks. We look at their MRI scans, looking to see if we have new lesions or active lesions. And then we look at a variety of other metrics, such as things like their fatigue or their cognition. And we worry about safety concerns, monitoring their blood, if there are any other body issues going on, whether it be high blood pressure or cardiac or pulmonary. We have to monitor all that in. And if we find anything along that route that gives us concern that they're either inadequately managed or there's a side effect profile that we're worried about, their liver enzymes went up or the white count got too low or whatever it is, we may have to make a switch. Sometimes that switch is fairly straightforward. Sometimes we have to worry that depending upon what drug they were on and where they're going to go next, may be a problem potentially, because there could be sequencing issues there where you may have to wash a drug out for some period of time before you start a new drug, or you may not want to wash that drug out because you need to have a tail on it because the disease activity is going to come back, so you need to start a treatment right away. So there are a variety of pieces to that. And then one of the other pieces that we have very little control over is the piece called the insurance companies. And they unfortunately have an opinion about sequencing sometimes, or they say, this one's approved in our plan, but this one's not, so I can't let you use that. You got to try this first, which drives us crazy in reality. But the truth of the matter is, we know how to use these drugs from an efficacy standpoint and tolerability. We know the patients, we know what their concerns are, we know what the issues related to X, Y, and Z is, so we should be making these decisions.